Let's get Lith!
Today, we're diving into a super high-yield topic for Step 2, lithium. Let's break it down so you can nail those questions on exam day. Lithium is a classic mood stabilizer primarily used for bipolar disorder. The key thing to remember from the start is its narrow therapeutic index, which means the line between a therapeutic dose and a toxic one is very thin. So, how does it work? Well, the exact mechanism is still a bit of a mystery. But the popular theories you should know are its inhibition of the phosphoinositol pathway and its inhibition of an enzyme called glycogen synthase kinase 3, or GSK-3. Clinically, lithium is the first-line treatment for acute mania and for maintenance therapy in bipolar I disorder. It's also sometimes used as an add-on or augmentation for treatment-resistant depression. Now for pharmacokinetics, which is super important, lithium isn't metabolized by the liver. Instead, it's almost entirely excreted by the kidneys. This is a huge point. It means you absolutely must monitor your patient's renal function. If the kidneys aren't working well, lithium levels can build up and become toxic. Let's talk about side effects acutely. Patients might experience GI issues like nausea and diarrhea, as well as a fine tremor chronically. The side effects are more extensive and are frequently tested. First, it can cause nephrogenic diabetes insipidus by antagonizing ADH, leading to polyuria and polydipsia, meaning patients pee a lot and are always thirsty. Second, it can mess with the thyroid, causing hypothyroidism and sometimes a goiter. Third, watch out for hyperparathyroidism and resulting hypercalcemia. And finally, a classic association if taken during the first trimester of pregnancy. Lithium can cause Epstein's anomaly, a rare heart defect in the baby. Toxicity is a major concern. It's often triggered by things that reduce lithium clearance, like dehydration, poor kidney function, or drug interactions. Be especially careful with NSAIDs, thiazide diuretics, and ACE inhibitors. These all can increase lithium levels. Symptoms of mild toxicity include a worsening tremor and GI upset. As it gets more severe, you'll see confusion, ataxia, seizures, and even coma. How do you manage toxicity? First, stop the lithium. Then, start for fluids to help flush it out. In severe cases, especially if the level is over 4 or the patient has severe symptoms like seizures, hemodialysis is the answer. So, what do you need to monitor? Get baseline and periodic labs. This includes lithium levels, aiming for a range of 0.6 to 1.2. Also check renal function with BUN and creatinine, thyroid function with a TSH, and calcium levels. And of course, always get a pregnancy test in women of childbearing age before starting. To wrap it up, lithium is a first-line mood stabilizer for bipolar disorder with a narrow therapeutic window. Remember, it's cleared by the kidneys, so always check renal function. Watch out for its chronic side effects like nephrogenic DIA and hypothyroidism. And know that NSAIDs and thiazides can push a patient into toxicity. I hope this was a helpful, high-yield review. Keep grinding.